is prospective evaluation of a modified apnea test in brain death candidates that does not require disconnection from the ventilator. My name is Dr. Shrishti and my moderator is Dr. Ankur. So brain death is characterized by a triad of coma, brainstem areflexia, and apnea in the setting of adequate stimulus. So apnea test determines whether a loss of spontaneous respiration has occurred. So spontaneous breathing failure is defined when CO2 is PCO2 is greater than 60 mmHg, and some guidelines also require an increase of PaCO2 of at least 20 mmHg above an elevated baseline. So previously in 2010, AAN guideline said that only if one of the criteria would meet, then brain death can be determined. But now new guidelines of 2023 states that both the criteria of greater than 60 mmHg and PaCO2 at least 20 mmHg above a baseline should be there to characterize show that the patient is brain death. So disconnection of the patient from the ventilator is often performed to assess the failure of spontaneous breathing. So what is the main problem? Many of the candidates for the brain death have a pulmonary impairment due to aspiration pneumonia, neurogenic pulmonary edema, or ARDS. So the loss of PEEP upon disconnection from the ventilator can render the apnea test and make it difficult to even perform. So the aim of this study is to prospectively investigate whether modified apnea test performed without disconnection from the ventilator is safe, feasible, and applicable to a large number of patients, especially those with impaired pulmonary function. Ethics check approved by local ethic committee registered at the German clinical trial. Informed consent was obtained from the patient's relatives and no external funding was received. Study population, a group of 140 patients with severe brain damage due to various etiologies. From January 2019 to December 2022, patients were examined for the presence of brain death at various intensive care units within the University of Medical Center, Freiburg, Germany. So it was a brain death assessment was performed clinically by two experienced neurointensivists, both certified in both neurology and intensive care medicine, who had performed more than 100 brain death tests accordance with the guidelines published by the German Medical Association and the German Society of Clinical Neurophysiology. In most cases, brain death testing was required prior to potential organ donation, but in some cases, it was also performed for the purpose of end-of-life care. So it followed the German guidelines recommendation and it excluded the patient with COPD or pulmonary contusion who had high level of CO2 before the apnea test. And the baseline PCO2 recommendation was 35 to 45 mmHg. And hypercapnia should be induced by acute hypoventilation until PaCO2 value of 16 mmHg was reached. Review of all the cases, including the examination of all available cerebral imaging and laboratory data. All the confounders were ruled out, example sedation or shock. And clinical assessment of the brainstem reflexes, including an apnea test, was performed. A serum drug level for analgesic and or sedatives was obtained in the following situation. In the patient who had received analgesics or sedatives or other centrally acting drugs for more than 24 hours, if the last dose had been administered less than 48 hours before brain death testing, and if therapeutic hypothermia, which slows metabolism and medication breakdown, had been applied. The ventilators to which brain death candidates varied as follows. Draeger Evita, 21 total number 21 Draeger Evita was used, 65 V500 ventilators, 33 V800, 14 Evita XL, 2 Macworth Servo, and 5 Hamilton ventilators were used. Prior to the apnea test, the ventilators were set to either BiPAP or SIMV ventilation with a PEEP setting of 5. And to prevent hypotension, all patients were started on IV NORAD if it has not been already administered. The modified apnea test was performed as following. So pre-oxygenation was done with 100% FiO2 for 10 minutes and arterial blood gas analysis and PaCO2 measurement was done. The target of PaCO2 was 35 to 45 mmHg. PEEP settings were then increased by 2 points and the flow trigger was set to 10 liter per minute. Automatic apnea backup ventilation was turned off. The acoustic apnea alarm time was set to 60 seconds. The ventilation mode was switched then to CPAP and the timer was started. The patient's thorax and abdomen were undressed and closely monitored for breathing attempts and thorax excursions. Machine display was set to show spontaneous versus ventilator-induced breath and airflow liter per minute to control for pulse synchronous airflow caused by cardiac vascular pulsation and to prevent auto-triggering. Basically, because of the beating of the heart, the cardiac pulsation, which are known as cardiac oscillations, that are generated, and because of the close proximity of the heart with the lungs, they are transmitted to the lung and it can be shown in the airflow graph. The main concern with the cardiac oscillations are that it can trigger auto triggering. That means it gives the breath to the patient without patient's effort, and other thing is that it also mimics the spontaneous breath. So if we display the airflow liter per minute, then it will be easy to differentiate between the cardiac oscillation and the patient triggered breath. So blood gas analysis was repeated after 6 to 8 minutes. The apnea test was deemed positive if the PCO2 was 60 mmHg and spontaneous breathing was absent. The ventilator was then immediately switched back to pre-apnea settings. If the PCO2 was below 60 mmHg and the modified apnea test was continued in CPAP mode, and blood gas analysis was repeated until either the mentioned PaCO2 target value was reached or spontaneous breathing attempts were witnessed. If spontaneous breathing attempts occurred before the 8-minute period had passed, the apnea test was aborted and the ventilator was switched back to pre-apnea settings. For the patients on veno-arterial ECMO, the modified apnea test was performed in patients using the protocol previously described. ECMO settings were adopted with FiO2 to the membrane lung was set to 100%. The sweep gas flow was reduced to 0.5 to 1 liter per minute and the pump flow remained unchanged. This was sufficient to achieve a rise in PaCO2 in all patients. Statistical analysis and data presentation. Statistical analysis were performed using the IBM SPSS Statistics 21. Data were found to be non-normally distributed and are presented as the median with interquartile range. The performance of the modified apnea test was assessed in relation to the extent of pulmonary impairment. So the pulmonary impairment was determined by the reference to Horowitz index, basically the PFR ratio. 10 minutes after the pre-oxygenation, and PEEP was 5 mmHg, and all the patients were characterized on this basis. No pulmonary impairment with PFR greater than 300, mild PI with PFR of 201 to 300, moderate with PFR ratio of 100 to 200, and severe with PFR ratio of greater than 100 mmHg. So basically, this is the chart which shows the patient characteristics of all 140 patients. So 82 patients were male and 58 were female. So modified apnea test were initiated in 139 patient. One patient was excluded because he was too hemodynamically unstable to go the modified apnea test. And modified apnea test was positive in 127 patient. And spontaneous respiration was observed in 12 patient. Duration of modified apnea test was median time of 15 minutes with range of 13 to 90 minutes. So different etiology of brain lesion were included. The highest being hypoxia, then combined, then ICH, SAH, ischemic stroke, and others. So 16 patients were on ECMO, and and 5 patients had COPD, that baseline CO2 greater than 60. In 9 patients, relevant level of analgesia sedatives were present. And 32% of the patient had no PI, 12% had grade 1 PI, 33% grade 2, and 22% grade 3. So brain death was confirmed in 114 patients and not confirmed in 26 patients. Among 26 patients, 12 patients had spontaneous respiration and 9 patients had relevant levels of analgesic and sedatives positive, and 5 patients had COPD. So basically in 26 patients, brain death was not confirmed. So here, this is the graph showing the PaCO2 level. So this is the whisker and box graph. Here, this blue color box, it shows the interquartile range. That so it means that 50% of the patient had the CO2 value within this range. That is between 35 to 45. And the lower end of this blue pot is the Q1. It's the first quartile, which means that 25% of the patient had CO2 value below 35. And the upper border of this box represents the third quartile, which means that 25% of the patient had CO2 value above 45. And this whisker extends from the first quartile to this whisker extends from the first to the end part, which means that this end part of the whisker signifies the lowest value and the highest value of CO2. So basically, the pre-apnea CO2 was between 35 to 45, and the post-apnea CO2 was between 65 to 75. We can also see some outliers. If the CO2 values are more than 1.5 times the interquartile range, then they are shown as outliers in the graph. So we can see basically one patient even had the PaCO2 of 100 mmHg. So here we can see the pre-apnea test oxygenation and post-apnea test oxygenation value according to the grades of pulmonary impairment. In grade 0, we can see there is no much of difference between the oxygenation uh, pre uh, uh, apnea test and the post apnea test. But as the grade of impairment increases, we can see the significant difference in the post apnea test oxygenation level. You can see that as the if the patient has grade 3 pulmonary impairment, the post apnea test oxygenation values are significantly increased. Now, patients on ECMO, 16 patients were under ECMO treatment at the time of apnea test. No significant hypoxemia or desaturation was noted during the modified apnea test in these patients. A rise in PaCO2 to at least 60 mmHg was achieved in all the patients solely by reducing sweep gas flow without additionally altering pump flow. So basically, deoxygenation is one of the complications of the apnea test. So in this test, it was not necessary to interrupt or abort the modified apnea test in any of the 139 patient. No significant difference in values pre modified apnea test minus post modified apnea test was found in patient without PI. I've already explained that. In contrast, the percentage with higher post modified apnea test was significant in patient with mild PI and highly significant in patient with moderate and severe PI. So when compared with the pre-apnea test, modified apnea test PaO2 levels, post-modified apnea test O2 levels were reduced in 51 patients, but were equal or higher in 88 patients. But there was no case in which the oxygenation was less than 60 mmHg in the post-modified apnea test. That is, no post-modified apnea test induced hypoxemia was found. So here, this graph shows the difference between the pre-modified apnea test oxygenation level and the post-apnea test oxygenation level. We can see that as the grade of pulmonary impairment increases, the difference between the oxygenation level increases. So in grade 3, we can see the higher oxygenation level compared to grade 0, 1, and 2. Cardiocirculatory issues in the majority of patients, that is 123, blood pressure was found to be lower post apnea test than it was prior to the apnea test. This blood pressure has occurred in the last minutes or after modified apnea test in all these cases. So a total of 104 patients received IV NORAD before the modified apnea test was initiated only. And a NORAD perfuser was prepared and connected prior to the apnea test for the remaining 35 patients in which it was not initiated prior. So a MAP transiently dropped before 60 mmHg in 12 patients, thus requiring a dose of IV NORAD to be transiently increased. No other severe complication during the apnea test was observed. So discussion, apnea test is a central component of brain death and determination of for the brain death. Traditional apnea test involves disconnection of the patient's endotracheal tube from the ventilator with or without additional use of TPs or resuscitation bag with CPAP valve in de-recruitment, resulting in de-recruitment, desaturation and early termination. Previous studies have reported that execution of the apnea test was impossible in 4.3 to 7% of the patient because of cardiopulmonary instability and was further aborted in 1.6 to 3%. So this is the article, apnea testing for the determination of brain death, a systemic scoping review published in Neurocritical Care in 2021. So basically it took the review of all the articles published since 1960, and it screened 381 articles and 89 articles were included. So it found out that the complications with apnea testing, hypertension was present in 7 to 39% of the patient, hypoxemia in 4 to 6.3% of the patient, and arrhythmias in less than 1 to 1%, with cardiac arrest with 0 to 0.7% of the patient. So it also so different types of modification of apnea test has been used. First one being adjustment of the oxygen insufflation. Here we use we deliver the oxygen via the catheter that is less than 70% of the internal diameter of the ET tube, and we set the flow to 4 to 6 liter per minute, which gives adequate oxygenation to the patient, and the flow is not that high to cause the CO2 elimination. And the modified apnea test with maintenance of positive and expiratory pressure. It can be done by using a T-piece with a CPAP valve at the outflow, or use of a traditional T-piece connection to a reservoir, one end connected to the reservoir bag and another end is connected to the outflow tubing that is immersed to the water at a depth, and according to the depth of the water, the PEEP can be adjusted. And third one being the carbon dioxide augmentation. So basically, if the patient is hemodynamically unstable, we can use a CO2 cylinder and just insufflate the patient with carbon dioxide at the rate of 1 liter per minute, so that the CO2 of 60 can be attained in 1 to 2 minutes. But this method has not been implemented because of its contraindications and because of the availability of carbon dioxide cylinders. Augmentation of oxygenation can also be done by doing the recruitment maneuver by increasing the PEEP. But recruitment maneuver now they are not supported in patient with ARDS. So this is also not used that much, and the literature is also not there regarding that. So basically, the articles they found that when comparison of apnea test with oxygen catheter, TPs and CPAP, there was significantly less decrease in PO2 with CPAP versus oxygen catheter or TPs, and ambu bag with PEEP valve resulted in stable PFR ratio. And when the oxygen insufflation was compared with CPAP, there was gradual decrease of PA to FI2 ratio with conventional apnea test when compared to the CPAP apnea test. And it also showed the comparison of modified apnea test to conventional apnea test. Similar, there was similar duration of apnea test, similar changes in PaCO2, PaO2 or pH, but there was a definitely reduction of there was decrease in desaturation or arrhythmias. So basically, modified apnea test is superior to apnea test in to prevent the hypoxemia in the patient. This is the another article, proposed safe apnea test using positive and expiratory pressure valve and short-term blood gas analysis. This basically compared the traditional apnea test with the modified apnea test using an ambu bag delivering 100% of the oxygen. So it found that there was no significant changes in PaCO2, PaO2 or pH, but modified apnea test prevented dramatic reduction in PaO2 and SaO2 in the patient who had hypoxic brain injury. This is also another article, apnea test on conventional mechanical ventilation during brain death evaluation. So it was published in 2024. So it was a retrospective study. So it examined all the records of the adults who underwent apnea test as a part of brain death evaluation between 216 and 222. So 92 adults were included, in which 58%, 63% with mechanical ventilation and 35% with oxygen insufflation. So it found that hypoxemia occurred in 12.5% of the patient with oxygen insufflation, and to, with oxygen insufflation, and zero patients in mechanical ventilation. And hypotension occurred in 5% with mechanical ventilation and 12.5% with oxygen insufflation. So apnea testing on conventional mechanical ventilation is feasible and often offers potential advantage over other techniques. So in this cohort also, only one of the 140 patient tested was considered too unstable to undergo the modified apnea test, whereas in the remaining cases, there was no need for the test to be aborted. Loss of PEEP that results from the disconnection might lead to cardiopulmonary instability, particularly in patients with concomitant severe pulmonary disease such as ARDS. It is important to consider in patients in whom it is difficult to rate apnea test as positive. It can be patients with an absence of spontaneous respiration at PCO2 greater than 60 mmHg can be because of the loss of the central respiratory drive or other factor. In cases of the pulmonary impairment due to COPD or chest contusion, patient may patient may tolerate hypercapnia. So in this patient, we cannot go with the apnea test. And even with the patients with lesions in the upper cervical spine cord, it is difficult to distinguish between brainstem areflexia and the central failure. Partial or complete respiratory failure caused by the lesions in the anterior neurons, C2 to C4, or nerve tracts of the phrenic nerve. In these cases also, it is difficult to differentiate the central brainstem areflexia or the central failure. PEEP settings were increased by 2 points, which allowed adequate alveolar oxygen circulation and ensured sufficient oxygenation in all patients. So no desaturation was observed despite the median apneic oxygenation duration of 15 minutes. 2-point increase in PEEP without ventilation did not result in CO2 washout, which permitted the required PaCO2 increase to greater than equals to 60 mmHg. After 10 minutes of pre-oxygenation, the patients were classified according to the level of PI, grade 0 to 3, in accordance with the modified Berlin definition of ARDS. So in patients with no grade PI, I've already mentioned there was no significant difference between the pre and post MT. But in contrast, patient with mild PI showed a significant increase in post modified apnea test PaO2 with p-value less than 0.05, whereas this difference was more pronounced and highly significant with p-value of less than 0.01 in patients with moderate grade 2 and severe grade 3 PI. So basically, the apneic oxygenation, that is cyclic alveolar recruitment and de-recruitment, is omitted in the patient with a modified apnea test, as the patient is not disconnected from the ventilator and the PEEP is maintained. Increase in PaCO2 is known to cause the possible drop in blood pressure because the drop in pH acidosis during the apnea test can cause the vasodilation, cardiovascular depression due to the direct inhibition of the cardiac and smooth muscle cells contractility, and acidosis induce reduction in the vasoconstrictive effect of catecholamines. So drop in blood pressure that always occurred towards the end or after the modified apnea test. So it was attributed to hypercarbic vasodilation rather than to the increased PEEP. Norepinephrine was administered in candidates prior to the initiation of modified apnea test as means of general circulatory stabilization. Specific minimum blood pressure standard for apnea test, that is systolic blood pressure greater than equals to 100 and MAP greater than equals to 75 mmHg, was maintained. In few patients, MAP transiently dropped below these thresholds, even to less than 60 mmHg towards the end of the modified apnea test. But a transient increase in the dose of IV NORAD was sufficient to correct this. None of the patient experienced critical destabilization of BP, despite the occurrence of high post-modified apnea values in some of the cases. Circulatory complications like arrhythmia, circulatory arrest that have been previously described did not occur, and this also held true for the 16 patients in this study who were treated with ECMO. So mainly disconnection from the ventilator has been advocated in past to clearly distinguish auto-triggering, which may be falsely interpreted as ventilatory drive from the real patient. So direct visualization of the airflow on the monitor is should be there, because the cardiac oscillation that I had described previously, they are pulse synchronous. So according to that, we can increase the flow trigger, and we can distinguish the cardiac oscillation from the patient triggered breath. Because the modified apnea test could be performed without significant complication in 139 of 140 patients, omitting disconnection from the ventilator when performing the apnea test is suggested. But the limitation of this study was it was a single center study. Patient with upper cervical cord injury and with COPD were excluded. And it also depends on the availability of ventilator, which has the direct visualization of airflow, adaptation of the flow trigger, and complete shutdown of the apnea ventilation. So conclusion, modified version of the apnea test has been described without disconnection from the ventilator. It is performed in combination with an increase in PEEP. Modified apnea test represents a safe and easy means of determining central respiratory drive status, particularly in patients with pulmonary impairment. Hello?
Yes, yeah, ma'am. Any questions or any comments?
Yeah, I wanted a small clarification. Actually, two. What do you mean by scoping review? What does scoping mean?
Scoop. Ma'am, I did not get you.
This is a scoping review. No, you showed one of the papers which said it as a scoping review on the matter. So, when is a review called a scoping review?
Ma'am, I don't know.
It is for everybody to find out. Okay, all the attendees. Second thing, the graphs you showed, no, the oxygen and carbon dioxide, yeah, this one. So, what is the central line within the box? What is the meaning of the longitudinal line and the width of the two ends on the longitudinal line? Just educate with respect to nothing with respect to this study. What exactly do they mean?
This middle dash line represents the median. That is which says that 50% of the values are 50% of the values rise above this. Suppose if this is 50 mmHg, then the 50% of the patient have oxygenation above 50 mmHg and 50% below 50 mmHg. And this represents the first quartile, that is 25% of the data lies below this. This upper one represents the third quartile, that is 75% of the data lies below this. And this represents the maximum value, this represents the minimum value, and this whisker extends from the third quartile to the maximum value. And these are the outliers. If they are outside, if they are more than 1.5 times the interquartile range, then they are represent outside the whisker, and it is known as the outliers.
So if you see this one with the oxygenation thing, the two ends on the vertical line here are very narrow. In the oxygen one, it is much broader. What is the difference? Just put the oxygen curve, no? Oxygen graph.
This one.
Yeah, never mind. Continue what you were saying. I think you've clarified yourself.
Can I go forward with critical appraisal or? we'll discuss something.
Others, whatever doubts you have, please go ahead and ask.
Ma'am,
Here
I do
now.
have a doubt, ma'am. Sorry to bother you, ma'am. Dr. Gopi, ma'am.
Please.
What was the maximum drop in pH in this study, ma'am? Like
Sir, it's
during the
not
test,
mentioned.
did you go through any individual protocol, any analysis, ma'am? Any individual persons, individual data, like any supplementary article was available?
No, sir, I didn't go through that.
Because like you said, there was not much of hemodynamic instability for all this. Almost 90% of the patients did not have much of hemodynamic instability. Even if it had happened, it happened almost at the end of the test, if not after the test.
But sir, they started with NORAD prior to the procedure only.
That was preemptively, ma.
Pre-empty only they started with the
So
NORAD.
if they had mentioned any inotropic score prior to doing this test, and the extent of pH drop, if that information was given,
No, sir,
probably that might shed some light. Like, no, it is like almost like most of the patients are pretty stable, except for the ventilator. Like you said, like almost like I think like from the data, like I think some 30%. Like, what is the PF ratio, ma? Like who had like between 200 to 100 to 200, less than 100. I
sir,
think
yes,
in those set of patients, like
22%.
only the respiratory parameter alone is unstable, whereas the hemodynamic component is pretty stable.
Sir, actually, it has mentioned that in 104 patient, they already received IV NORAD before the apnea test. And in remaining 35
what was
patients were started.
What was the dose of requirement of norepinephrine in those set of patients, no?
Sir, it was not mentioned in the article.
In 12 patients, the arterial pressure did go below 60, but then they said that their NORAD was increased. That's it, right?
Yes, sir.
So they tried to maintain the blood pressures due to noradrenaline infusion, and they kept titrating it throughout the test.
Systolic greater than 100 and mean greater than
That
75.
was started, yeah. So it was maintained by that. So the basic confounding factor were all ruled out. I had a few queries again. Number one was that what was the need for this test when similar articles were present, before, I mean, they were published in 2017, 2018, then why did this study was planned? Srishti?
Yes, sir. I'm not sure.
Anybody can answer. Only Srishti doesn't have to answer. Anybody, please.
If you have read the article, you would know.
It was pretty clearly objectively done. The way the ventilator settings were, a proper ventilator with proper display, including the airflow display, and where the apnea alarm can be completely shut down. Not only physically being monitored, but on top of that, objectively it was monitored with the ventilator.
One point is okay, objective. Second was the sample size was very good, 140 patients. Previously, only small sample size studies were done, mostly retrospective. This was to study the safety and feasibility of without disconnecting it. I mean, previous studies, what they were doing is they were disconnecting ventilator and they were attaching PEEP valves and kind of those kind of stuff to give CPAP continuously. Here they did not disconnect the ventilator. Firstly, and secondly, it was a large sample size study to assess the safety and feasibility of not disconnecting the ventilator and then doing this modified apnea test. Thirdly, this was taking into consideration patients with different etiological factors. I mean, different etiologies, along with even patients with mild, moderate, and severe pulmonary impairments, as you could see in this chart, right? So the patients with even pulmonary impairment were involved in this, and not only the this good set of patients who had good lung PF ratios to start with. So these were all the strong positive points to carry out this study. Actually, this was just a safety and feasibility study. There is no comparison with the conventional apnea test or something like a more, randomized control trial will be required in future, or rather it is ongoing also. where you compare it and then you find out what was the reason. Another thing was here, if you Srishti, if you go to the graph showing the PaO2, very interesting finding. Go to the graph, next results graph. Yes, stay over here. So if you see here, in the first, where there is no difference, I mean, there is no pulmonary impairment in the first section. Yeah, here. So there is a hardly any difference, even statistical as well as clinical, between the PaO2 values. But as the pulmonary impairment goes on increasing, your ARDS grade 2, grade 3, those kinds of grades of pulmonary impairment, you see that the PaO2 has actually risen up, which is a very interesting, but again, they're not able to explain it properly why this happened. If you it's like you're disconnect. I mean, you are connecting, you have the ventilator connected, you're not ventilating, you're not giving positive pressure, just CPAP, and the PO2 has started rising in ARDS patients. So that would be a very good modality. If you see in other ARDS patients, you want to transiently increase the PO2 level, you stop ventilating them. So that was a very, I found it a very odd reason. Like, what reason did they give, Srishti, of why the PO2 has increased in this population set of patients where
Ethnic oxygenation, de-recruitment was avoided with the PEEP.
basically connection was there, but you're not giving positive pressure. So the sheer alveolar stress, they say,
The cyclical
yeah,
swing between,
cyclical synchronization,
yeah,
desynchronization, that kind of
that was
that
avoided.
was given, but that has to be tested in further, prospective randomized articles before this can be actually clinically said. That otherwise everybody in ARDS patient would start stopping the ventilation and increasing the PO2s by this technique. But I don't know how this came up.
Ankur, this is very much along the lines why paralysis is advocated way in the beginning when PF ratio starts decreasing in ARDS. Almost along those lines. Very
Yeah.
interesting explanation actually.
Yeah, so basically that is what they're trying to tell you, that no, cyclical, this shear stress has to be avoided. So that is why you stop ventilating and you paralyze or you do whatever these things. So this was requiring that. Then and there were set of problems she has already explained. So that was done. Any other questions? Any people have any more?
Probably any comparative study, Mr. Ankur, like if they have compared one arm, probably some three arms, different modalities,
Yeah,
with a
so
good
that
volume sample size.
yeah, basically with the conventional, then without disconnection, or the third one with the PEEP valve or something like that. That could be another future study to plan and prospective randomized control trial.
Or any administration of carbogen, like without harming the oxygenation. If you can increase the rate of rise of CO2 rather than waiting for 8 to 10 minutes of time.
Yeah. They have
Or
given.
like, can we do any EIT where we can pick the uh, amplitude of contraction or electrical signal from the diaphragm?
It would be very difficult to get a ethical nod for that kind of a study. But I think the same group is also, in the end of the article, they are saying they are doing a comparative study between conventional ways and this. That will be interesting to see.
No, from the government, from the law point of view, legally, like, will be accepted as a apnea test, ma'am, like a
Of
positive
course,
test?
of course. When you attach to beam circuit and you do, when that is acceptable, what is the problem in this? You have switched off the apnea backup altogether. So that there is no chance that the ventilator. That's why they have given the details of the ventilator used. The old ones where you couldn't do these were not allowed. And in the limitation of the study also they have said this technique cannot be applied in older versions. So ethically there is nothing wrong in what they have done.
Okay. I think this will be more objective, ma'am. Particularly somebody who's got a high ventilator requirement where the conventional technique is not feasible.
Polytrauma patients are the perfect examples with predominant lung injury, lung and head injury. It will be very useful to apply in those patients. Yes, Srishti, continue. You never reached your property.
So coming back to critical appraisal, are the results valid? Yes, because all the candidates for all the patient with different etiology were included, and even the patient with pulmonary impairment with different degrees were included, and patient with hypoxia, patient did not have hypoxia and hemodynamic instability in our study, in this study. So was the cohort recruited in an acceptable way? Yes, I've already mentioned all 140 patients with different etiology and different gates of pulmonary impairment were included. Was the exposure accurately measured to a minimal to minimize bias? Yes, because the exposure
Prishti, you are not audible.
all the important confounding factors. Yes, all the mimics of brain death has been ruled out. Was the follow-up of subjects complete enough? So basically, 26 patients had apnea test negative, in which 12 had due to the presence of spontaneous breath, and 9 due to the presence of analgesic or sedative, and 5 due to the COPD. But we don't know what happened to those patients. Did they go for ancillary testing or not? So the results are there was no significant hypoxia and desaturation with the modified apnea test. So the results are precise because the prior studies also have showed that modified apnea test results in hemodynamic instability and avoided desaturation. Do you believe in this result? Basically, the hemodynamic instability and desaturation can be prevented, but increase in PO2 with increase in PI grade is still questionable. Will the result help locally? Yes, it can be. It can help because most of the patient with brain injury have some kind of pulmonary impairment. So this can lead. So this can be applied with pulmonary impairment patient, but availability of specific ventilator must be there. Thank you.
And even those airflow monitors and all should be present. Otherwise, it is very difficult to, see auto triggering and all those things.
So this is Lenin. I had just a thought process. Hello.
Yeah, please ask Lenin.
Yes, ma'am. Ma'am, if this modified EAT is accepted, what will be the incorporating ETCO2 in this test? How it balance the test, since the mean duration was 13 minutes in the study? Will it helps in reducing that time duration?
Well, the whole technique and the rate at which the CO2 rises will remain the same as conventional. That is not going to be affected. The issue is the oxygenation. So continuing to monitor EtCO2 and repeated ABG drawing will remain the same.
Okay.
How will the time differ in conventional?
No, if we take ABG to see the PCO2 after 8 minutes, in ETCO2, if it is occurs within 4 minutes or 6 minutes,
Ma'am,
because we know
Lenin's
that
point of view is that it is a dynamic parameter wherein like you don't have to wait for 8 to 10 minutes of time as with conventional test for then do an ABG. If the ETCO2 can let us know prior to 8 to 10 minutes of time, that is well sufficient. That is what his point of view, ma'am.
yes.
But provided if the gap between the ETCO2 and PaCO2 is constant, if it is narrow, if it has not been affected by any other lung pathology, that might hold. I'm not sure, Ketu, we have to try and see. But whereas as Srishti was saying, for this patients who had a PF ratio compromise, like in the category of 100 to 20, 200 and less than 100, I think we can't rely with ETCO2 in it.
Okay, sir.
Srishti, how much is the CO2 rise per minute of apnea that you induce after disconnecting the ventilator or applying CPAP or whatever?
Rate.
The rate of rise in CO2. Why do we say it?
How do you
It's
basically
approximately
how
3
do you
mm per
calculate the
minute.
time?
Yeah, how did they come to that 8 to 10 minutes that you should take the first ABG? Why not after 15 minutes? Why not after 20 minutes? So what is the rate of rise in CO2? Somebody was saying, yeah,
It is approximately 3 mm per
yeah,
minute.
so
sir.
basically it differs, but medianly you say that it's 3 to 5, yes, something like
Okay,
that.
sir.
But different articles give a range of even 0.5 to 10, you know. So
Okay.
it's different. And of course, it depends upon the underlying disease or even COPD or something like that also. COPD patients have normally a different cutoff of before they actually get triggered their breathing, right? They have much
Okay,
higher.
sir. Okay.
So those were actually eliminated from this study.
Srishti, why had they taken off the COPD patients in this study? They couldn't get a 20 mm rise from the baseline.
Ma'am, actually, in German guidelines, they were excluded only, but in AN guidelines, they say that if the patient has CO2 greater than 60, if the patient is COPD patient, then we should know the baseline of that patient. So if the baseline of the patient is known, that we can take we can ventilate and take the patient's CO2 to the baseline level, and we can see if there is 20 mm rise from the baseline. But if the baseline level is not there, then we should go for the ancillary testing after apnea test to confirm brain death.
Thank you. If nobody else has any questions, again, Srishti, well done. Back to back with very good performances. Thank you very much. Ankur, once again, ever so grateful.
Thank you.
And today's session was really good.
A nice
But only one
presentation.
person spoke. Others should also wake up. Thank you very much, Dr. Gopi. I
Thank
wish
you,
more
ma'am. It was
teachers
a
would
good
join in.
presentation, ma'am. Nice, ma'am.
Yeah.
Ma'am, if all the reference articles pertaining to the class, if it's been dropped earlier, probably we'll have some sufficient time to go through the
We'll make
articles.
sure of that. Yeah, like this time we'll make sure the article is put up.
Yes, ma'am. Yes, ma'am.
At least
Sorry.
2-3 days. All right, everybody. Thank you.
Thank you. Thank you,
very
ma'am.
much.
Thank you.
We see you next week.
Thank you, Uncle. Thank you, ma'am.
Thank you. Good night.